Every day, a large number of people, both children and adults, experience medical intervention and care at Triple M. They walk in through the doors of Triple M as patients and walk out with a new lease on life. The Madras Medical Mission Hospital, since 1987, has been synonymous with excellence in patient care and quality medical treatment at an affordable cost, and it continues to draw a large number of patients from various stratas of the society. The Institute of Cardiovascular Diseases, ICVD, at Triple M has many firsts to its credit, including the first adult and pediatric heart transplantation in the private sector, percutaneous pulmonary valve implantation, first bilateral lung transplantation, first Ross procedures, first Batista procedure, and so on. The Institute is made up of several departments, including departments for adult and pediatric cardiology and surgery, and a department for cardiac rehabilitation. It is also home to some of the finest cardiac specialists in India. The Catheterization Lab at the Cardiovascular Diseases Department is a state-of-the-art facility that brings in a multidisciplinary team of doctors. It is here that diagnostic angiographic procedures and therapeutic interventional procedures are performed. With every surgery performed, with every patient treated, the Cardiovascular Diseases Department at Triple M reinforces its commitment to its missionary values. Every patient that comes in for treatment at the department, from a day-old baby to a 90-year-old, is an opportunity to further the Madras Medical Mission's goal of reaching out to the unreached.
Hello, Siva.
Yeah.
Yeah, this is Kogo here. I'm in the Super Center with me moderating this session. Yeah.
Hi, Ko. It's a pleasure to join you all, and our greetings to Sir Professor Qureshi, who was the principal investigator of the valve and the mentor for all of us. May I request one of my colleague, Dr. Anand Kumar, to give the PowerPoint presentation of the patient and give the patient details. Anand?
Yes, sir. Our patient today is an 18-year-old boy with class 2 effort intolerance, significantly increased RV volume on cardiac MRI. So he was diagnosed with TOF in newborn period and underwent intracardiac repair with transannular patch at 1 year of age in 2005. He developed occasional effort-induced palpitations and dyspnea on moderate exertion since past 2 years, and his MRI done in 2020 showed moderate RV dilatation, pulmonary regurgitation with regurgitant fraction of 37%, mild AR, RV ejection fraction of 53%, and mild LV dysfunction with the ejection fraction of 44%. He was started on carvedilol and ramipril. His chest X-ray showed mild cardiomegaly with a CTR of 60%, RA enlargement, RVOT enlargement, and a left arch. His ECG showed first degree AV block with a PR of 220 millisecond, probably due to the beta blockers, complete right bundle branch block, then axis of 60, and QRS duration of 160 milliseconds. His transthoracic echo showed severe free PR, VSD patch was intact, a mild AR, dilated RA-RV, mild biventricular systolic dysfunction, and a stretched PFO shunting bidirectionally. This was his cardiac MRI, which showed dilated RA-RV with RV end diastolic volume indexed for 140 ml per meter square and RV end systolic volume indexed, which was 66 ml per meter square. These are the two videos which show severe PR with a PR regurgitant fraction of 37%. And RVEF was preserved, which was 53%, and LV ejection fraction was 43%. We did a CT pulmonary angio, which gave a pulmonary annulus of 32 into 21 mm, and his sagittal, axial, and coronal sections were taken, which gave an annulus of 32 mm, and the RVOT was 30 mm long. And RVOT angiogram in lateral view gave a proximal RVOT of 27, mid RVOT of 32 mm, and distal of 29 mm and 37 mm long. And the angio in RAO cranial view gave a proximal RVOT of 27, mid RVOT of 29, distal RVOT of 25 mm and 29 mm long. The RVOT angio in LEO cranial gave a proximal RVOT of 32, mid 39 and distal 29 mm. Balloon sizing of RVOT was done. In lateral view gave, there were two ways. Proximal was 29 mm and distal 27 mm. And in RAO cranial view, proximal was 29 and distal was 27 mm. And LAO cranial gave maximum waist diameter of 31 and 30 mm. There was a stretched PFO which balloon sizing of which gave a waist diameter of 16 mm. This is the oximetry analysis that we did today, which gave a QPQS of 1.75, PA pressure of 25/5 with a mean of 13 millimeters of mercury, and the PVRI was 1.1. So the SD can be closed. So this is the summary of the RVOT interrogation details with the maximum diameter of 31 mm, and there was no coronary compression. Over to live demonstration.
So thank you, Anand, for the presentation. This MRI was done close to 2 years before, and between these 2 years there is much more visible enlargement of the right ventricle on the echocardiogram. So due to certain economic constraints that exist in many developing countries, we did not go for a second MRI, but compared to the echocardiogram that was done in 2020 and 2022, there was much more marked dilatation. Probably some of the dilatation is contributed by the PR, some of them is also contributed by the atrial septal defect that is present in this patient, which was shown by shown on the balloon sizing by Anand in the last PowerPoint presentation. The patient has got quite a significant pulmonary regurgitation with RV dilatation, and hence we were planning to consider a valve implantation in this patient. Shaq, any questions about the indication? You can say that the previous 2 years before, the volumes were still within the acceptable limits of, say, indexed RV end diastolic volume was 140, but we could appreciate more dilatation in this last 2 years on a serial echocardiography. So we decided to go ahead with the valve.
Yeah, that's fine, isn't it? Because, I mean, we would repeat the MRI and compare the volumes before proceeding, but it sounds reasonable. There's still controversy around whether we should be lowering the end diastolic volume indication for percutaneous pulmonary valves to 140 anyway. So, yeah, I mean, he's pretty much
on
reached the stage of
on certain parameters that we tracked, like tricuspid annular plane, systolic excursion, fractional area change and all, there is a marginal decline in the RV function. As well, there was visibly more RV dilatation during this present echocardiogram compared to what we saw 2 years before, and hence we decided to plan a valve. He's also entering into university now. So considering many factors, we decided to go for a valve.
Yeah, no, that's fair enough.
Now, about the balloon sizing, we had to actually perform the balloon sizing earlier because I was just listening to Supa mentioning that she has a limited supply of the valves. In fact, we too have the same constraint. In fact, in this particular patient, I have only one valve and one delivery system that I can use. So it is basically there is a lot of restriction about bringing in the products into the country right now, and hence we have gone for one valve. But anyhow, let us discuss the sizing. The size on the balloon waist as well as the angiogram was anywhere between 29 to 32. The largest was 32, but in majority of the places it was somewhere around 30, 31, 29. I can show you. Yep.
Shiva, don't tell us what size valve you've got available yet. So let me just ask,
Okay.
I will,
let me just ask.
Shaq, I will give you a new angiogram today, and then
Okay.
show the size also. Show that this is the first we crossed the atrial septal defect to record the QP by QS, which was around 1.7, 1.75. This is the first angiogram in RAO projection. I'll give you the measurements next. Second, this is in LAO projection. Both the branch pulmonary arteries are reasonable in their sizes. There is a distal main pulmonary artery, a slight constriction, then a little bit of ballooning of the main pulmonary artery. Again, there is a constriction at the level of annulus, and then the right ventricle is below that. Next picture. So here again we can see the two levels of constrictions. The pigtail tip is at the level of the distal MPA constriction, and the somewhere proximal behind the second sternal wire is the annular constriction. I will show you some of the measurements. Show the photo.
Yeah, Mr. Siva, can I interrupt for a while? You always do the MP angiogram with the wire inside too, right? Just to, is that so?
Yeah, we have put in the Lunderquist wire already before we shot the angiogram, so that whatever the type of distortion of the RVOT will happen, we take into consideration those distortions created by the wire. Of course, there could be a point that the wire may be distending the RVOT in one particular plane where there is a guide wire bias. But since we are taking in 3 orthogonal views, one in steep RAO at around 40, and then one in LAO of around 40, and then one in lateral of around 90, we feel that it may average out. What is your thought about keeping the wire while we are doing the angiogram?
Yeah, I'm just thinking, this is something new I learned. I never put a wire in before. So it is, today I do learn about some of the wire that can distort the anatomy. Probably best is we do it with the wire. Of course, you are putting in the LPA, meaning that you're going to deploy from the LPA instead of either both RPA or LPA.
Yeah, based in this particular patient, we had done a CT scan, and in the CT as well as in the MRI, the main pulmonary artery was in direct continuity with the left pulmonary artery. So we made up our mind that we are going to start our first trial through the left pulmonary artery. The LPA was more in alignment. Show the previous LAO angiogram. The LAO angiogram. No, the acquisition. Show the acquisition, the correct. You can see here my guide wire that is going from the right ventricle, outflow tract, pulmonary annulus, and across the LPA is more in a reasonable alignment. Now show the RAO angiogram. So I feel that the left is more in alignment in this patient, and hence we were thinking about putting the stiff wire in the left as well as valve from the left. Shaq, what are your thoughts about these 2 angiograms and like placing the guide wire in the left and deploying from the left? That is question number 1. And second question is, will you do an RVOT angiogram without any guide wire at all, so that you get the undistorted RVOT dimensions?
Yeah, my preference has remained initial angiogram without any distortion, without any wire in place. I just get a sort of some better understanding in some of these cases where the branch pulmonary arteries may have a fold or an unusual origin. Putting a stiff wire in first distorts that. So I tend not to do wire in position first. Delivering this valve from LPA looks, from what you've shown, it looks a reasonable approach, I think.
Now coming to the size, okay, now show the photos. Prabhu, show the photos, the stored images. See, this is the right ventricle, this is the RAO projection. Here we are getting a maximum of 27 millimeter at the, this is at the level of the mid main pulmonary artery. Actually, we had made a lot of measurements in the pre-procedural angio. Okay, this is this. Show one by one. Don't run. This is in the LAO projection. The maximum dimension is in the middle of the main pulmonary artery, which is around 30, 32 to 33. But the proximal pulmonary waist is 28.6, around say 28 to 29. Right and the left are almost equal, 17 and 19. The length of the outflow tract between the place of the pulmonary artery bifurcation to the level of pulmonary annulus is around 25. But I want to show one, okay, now show the another picture. Okay, so here if you see in the lateral view, the distal part of the main pulmonary artery pre-bifurcation is around 28. The proximal portion of the annular region was little smaller, it's only 22. But if we see down, that right ventricle is actually sort of constricted there. The right ventricle was quite narrow. Can you now show me this lateral view angiogram live? I'll just show that picture once again. RV lateral view. Okay, keep on running it. Here, if you identify, the pulmonary annulus is seen just behind the second sternal wire, and between the second sternal and the third hidden sternal wire is the right ventricular outflow tract, which is actually smaller. So we considered between a 25 millimeter and a 30 millimeter valve, and I was worried about a 25 millimeter valve, because the 25 millimeter valve will have the entire distal flare significantly restrained into that right ventricular outflow tract, and may stand a chance of fracture of the proximal flare. So if I get a 30 millimeter, little bit longer, I may get a little bit more of the most proximal part of the proximal flare, a little below. So we debated between a 25 millimeter length and the 30 millimeter length, and finally we decided for a 30. Now Prabhu, again show the dimensions, show the measurements. I'll once again show the measurements. Okay, so here if you see in the lateral, I stretched that region to 30. What we are seeing in the line is 30 millimeter, and below that will be my proximal flare. So I would anticipate the proximal flare, so the proximal part of the venous valve, which is going to sit in the right ventricular outflow tract, where there may be some amount of dynamicity. There may be a possibility that there may be a fracture of the proximal flare stretch. The main portion of the valve, which is going to the middle portion of the valve, which is going to have the leaflets, probably will not be dynamic, because that is in the main pulmonary artery. But the proximal part of the flare may be in a more dynamic area. So
Shiva,
yeah.
have you, just to move it a little bit, have you done balloon interrogation as well?
I have done the balloon interrogation during the previous study. I did not repeat it now. In the previous study, we got between 30, 31 millimeters balloon waist on various views. Between 30 to 31. If you want, I can show the PowerPoint once again, but it is there in the, it is not in the present study.
Okay, so Juku, do you want to advise Shiva on Shiva is not going to tell you what only valve he's got. So what valve size would you be recommending?
Valve and RV on the picture.
I think maybe valve size I would recommend 32, and the length maybe 25.
Okay, right. So and then Warrican?
That photo there.
Warrican?
Yeah.
Oh.
Maybe
Check, yes.
Zhangbin Pan. I was going to ask him about Shiva's. All right. So I'm getting confused now. We're with Super and also Shiva.
So maybe we discuss about the Dr. Shiva first, maybe.
Yeah, yeah. So that's what we were doing.
Microphone.
Yeah, so let's stick with Shiva. And I don't know if Zhang Bin Pan has joined or whether he can hear us and advise Shiva on the diameter.
Shaq, while you are discussing the size, I'm just showing the previous RV and PA simultaneous pressures, where
Okay.
the PA is ventricularized. You can see one slanting image that was just a frozen frame of the original hemodynamics that we got. Thank you.
Yeah.
Yeah.
Tin, any ideas? Let's keep moving fast, I think. Any thoughts?
Start flushing.
I think it's the size about 32 and 34, but the main thing is how about the size Siva have? She has only one only.
Yeah. We'll ask him in a minute. So I think if I was doing this and I had a choice, I'd be looking at 32 by 30. And I agree with Shiva's assessment of that length. He wants a flare a little bit more in the RV, so a longer valve would be fine. So Shiva, tell us what valve, the only size that you've got.
Okay, since we got the maximum waist at one of the lateral view angiogram was 32, we decided for a 34 by 30, 34 by 30.
Okay.
So, so now in a very delayed manner, I will now introduce all the people. Now, the person who is now loading the valve is Dr. Pramod Sagar, who is my associate, and the person who is now flushing is Ms. Lalita, the technical expert in our department. I have radiographers Surya and Prabhu. I have my intensivist Dr. Giridhar, who is managing the ventilation. We are doing it on general anesthesia. I have Gaurav, who is with me for the procedure, and Srija will join for the imaging a little later. Okay, now we have mounted the 3430. We have placed, now come to live AP. We have placed a 24 millimeter long Cook sheath into the proximal right ventricular outflow tract.
Sorry, Siva, can you comment about your Cook sheet? What's the French size of the Cook sheet? 24?
24.
And which sheath is it? What type of?
It's a Cook sheath. I will show you the sheath. Unlike Gore dry seal, this Cook sheath does not have an expandable valve. We have to go through the resistance. Little bit of propofol, please. Little bit of propofol in a bowl. So I will show you the Cook sheath now. Show here. So this is the Cook sheath, which is 24 French. It's braided, and
what's the length of it?
It's 65.
Okay.
I'm just a little bit more, Pramod.
And does it have a particular name, or is it just a?
It's a Cook. It's a Cook long braided sheath. I don't know the name. Nothing is written there. Yeah, flush it and close. Okay. Propofol.
There must be a name for it, because.
Can you show the power? Okay. Now we are showing you the. Okay. Now show it a little. Okay. It is called extra large check flow introducer. It's not a very specific name that I can remember. Very generic in nature. Generic name for a product.
Yep. Okay, so, carry on.
Now I am show here. So now I have used a little bit of propofol just to lubricate. You can see the whitish colloidal solution. So once it crosses the valve, it behaves a little better. So now Pramod is controlling the distal end, Gaurav is controlling the proximal end. We are now going angiogram later once again.
That's very nice demonstration of the use of the Cook sheath.
Go to LAO.
And whilst you're doing that, I'll just ask Joyce, about what she would have recommended in terms of size. Joyce?
Me?
Yeah.
Hello? If the balloon, the waist is 31, but the balloon, if the moving, then maybe we can go to the 34. But not moving, I agree with the Dr. Wang, 32.
Okay.
We made a jump there. Fluorostore this. Fluorostore. Show that fluoro. So there was some amount of resistance at the tip, but then we made a, at this point it jumped in. Okay, now
so really one of the problems, Shiva, is the fact that the sheets are still not long enough, because ideally what you want to do is have these sheets almost at the origin of the LPA, and then you don't have to
15.
force the system at the outflow tract.
Yeah, that sheath is quite rigid, Shaq, with this, it's a braided sheath, and it does not take the entire curve. It just supports me only up to the right ventricular outflow tract. What about the Gore dry seal? Does it go all the way to the left pulmonary artery?
We push it into the RPA as well as LPA. So
when I tried it with this sheath, it actually bends a little bit. But even with that bend, we will be able to still perform the procedure. But okay, ready for angiogram? I'll just see how deep I am. Angio ready? So now my entire distal flare is in the left pulmonary artery. I'll just loosen the tension. I'll just start opening from here and see how things are. What do you feel, Shaq? Just run that picture. Run that picture.
Yeah.
Keep running.
This is where the anatomy becomes a bit distorted, isn't it? And so I don't know if lateral is going to be more informative or not.
Okay, I'll do a lateral. Go to lateral. I thought of releasing about half of the distal flare and then going for another, but we will do one now. There is a pretty sharp bend on the valve there. Okay, ready for an angiogram? Yes. I am not too deep into the left pulmonary artery here.
Yeah, that looks all right there, doesn't it?
Siva, do you want to pull the long sheet lower down so that not so much of bending when you're pulling? Or?
We'll do that, yeah. Okay. I have so fluorostore this. I have pulled back the long sheath just outside the proximal flare. We will just open out a little bit. Still in this picture, show the previous one. In this picture, my distal, the proximal flare is still across the level of the annulus. Shaq, would you like me to go a little bit more deeper before I start opening, or this is okay?
I think this is okay.
Okay.
Shiva, yeah.
So I'll maintain a forward push, and then now Pramod will start opening the valve. Slowly keep opening. We all know that there is going to be a time before the tension on the valve, that delivery system is released. I would like to start this process in a RAO projection rather than here. Come to RAO. RAO cranial, the same view. Show that RAO cranial picture first. Yeah. Okay. Go more cranial. Just one angio here. start opening. I just made a little bit more push. Pramod is now coming out. The valve, the ring is slowly coming out. Okay, little bit more. So almost the entire distal flare has been opened out. Let's see once again. Let me see the LAO, injection in LAO. Ready for injection? So probably I can come a little bit out. Shaq, what do you?
Yeah,
okay.
agree.
Okay. Now keep opening a little bit more. Just hold on, wait for some torque to go. Sure. Okay. Ready for one more angiogram? Come to RAO. The entire flare is now still in the left pulmonary artery sac.
Yeah.
Shaq, can you hear me?
Yeah, Varakan, I'm hearing you.
Yeah, so
Yeah.
I'm back. Sorry, we just finished up the case, but yes.
What?
Yeah. So Shiva, one thing if I could share, if we open more beyond this point, it's very difficult for us to pull it back, I think. But you have God dry seal, right?
Something like a go dry seal.
Okay, right.
Yeah,
So
it's a
thank you.
cook sheath.
Cook sheath.
All right.
I'm going to make one more.
Extra long cook sheath.
Okay, so take your time, sir.
Now ready for angiogram. At this point, basically the proximal the markers that we have, the proximal markers that we have of the valve, the three markers, are almost at the annular level. So I would like to keep the valve at the same position and keep opening a little bit more so that the valve will foreshorten and fall back. What do you feel, Shaq? Varakan?
So allow me to say first and then check. If I were you, I may try to pull back a bit. See, because if I open more, maybe it's too difficult for me to pull back the flare, which is fully open there. So I may pull everything back a bit more.
Shaq?
Yeah, I agree with Borkan, but also I still think, I mean, you should do what you're comfortable with. I tend to rely more on the lateral projection in this sort of position.
Go to lateral view. See, in this particular LAO projection, the proximal flare is almost coming into the bifurcation now. In the RAO, this is RAO. The proximal flare is, show the previous picture. The distal flare. Here,
I think it's still in
deeper.
LPA, isn't it?
Deeper, right?
In the LPA.
Yeah. So I'll see one lateral now.
Yeah.
Ready for an angiogram? the RPA is below, the distal flare alone is just across the LPA ostia.
Yeah, it just needs to be back 5 millimeters, really.
Yeah, that
Yes,
5 millimeters, will I get it if I just deploy a little bit more? There will be some foreshortening of the valve, no? Go to LAO, RAO again. What do you feel? Show the previous LAO view.
I think I would still pull it a little bit now.
Okay.
5 millimeters.
Okay. Hold it nicely.
Obviously, very slowly.
So I am just giving a push on the wire. Okay. I have given a pull. I will be happy for Pramod to release a little bit more. Yeah.
Siva, I'm not sure whether the long sheet should be pulled a little bit down so that you can have more angle to the RVOT. I think the long sheet actually straighten the whole system a little bit more. Just a suggestion.
Okay. Okay. Now get ready for one angiogram. I think the proximal flare has opened across. Show an angiogram. Get me one LAO. Give about 20 ml at 15 rate, 20. Hold in the same position.
And a lateral as well, Shiva.
I want to just push the wire a little bit and see whether so I am doing it on scenic, disconnect the injection. Okay, now I am holding it in this position. I didn't see much of change, but I have actually reduced the tension on the system. Okay, go to lateral. Lateral. Ready for one injection?
Shiva.
Yep.
Just pull back the pigtail about a centimeter for this injection. You'll see why.
Okay. Is it okay?
Yep. Right.
So what do you think, Shaq?
The RPA
I think this is a place, right?
RPA
you think
is
what, sir?
I think this is a place for landing, right?
Yeah, pretty much. But if you look at the, I'm looking at the RV end as well, because Shiva was keen to have a bit more of the flare in the RV end.
Shaq, already my entire proximal flare is at the level where I want it to expand.
Right, yeah. That's what I was trying to get a better view of. And the lateral actually shows it, this view shows it better than the other views, I think, for that particular position. So I think you can start deploying more of the valve now.
Show one LAO here. Go to LAO. Ready?
Yeah. I think that's pretty much on at the right place, isn't it?
Yeah, looks quite good landing position.
So without any movement, tension, we will just keep opening the valve. I feel because actually I have reduced the tension on the cable and the wire.
And are you going to release it fully in this projection or in the lateral or what?
I know that you like laterals, so
Me too, Shiva.
I will release up to the middle of the proximal flare, make one more check and then come to lateral.
Okay,
That sounds
all right.
lovely.
Okay.
Thank you.
A compromise between both. Keep releasing. Come up to only the middle. Be very slow. Enough. Do an angiogram here.
Oh, the blood pressure may come down.
It's not because the patient is having on ASD. Okay, come to
Oh,
RMO.
okay.
Is the patient desaturating? Yeah, 88% saturation. Ready for one angiogram? Okay, go to Shaq. I'll be happy to release in this view,
Yeah.
Shaq.
Yeah, no, this is fine.
Because I can push it if needed. Okay, start releasing, Pramod. Yeah, 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 yeah,
Keep a little push.
yeah, 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 yeah. Full release. Okay. So, Sinif,
Very good.
store it.
That looks beautiful, Shiva.
Yeah, there are some ectopics, possibly, okay, because of the new flare coming and hitting. Okay, both the
Two
eyes,
ears coming.
both the eyes are also released. I will try to take out the pigtail. It's not, okay. Sister, give me a wire. I am just reintroducing the guide wire, taking out the pigtail, and if I have gone across into the pulmonary valve, fluorostore. The saturation has again come back to 100. It went down to about 85 when we were at the worst occlusion of the RV outflow tract. Little bit more cranial. More. Make the 3 dots come on a line. Okay, ready for injection? Are we okay on the right pulmonary artery, Shaq?
Looks like it, but I would still do a lateral.
Lateral, okay, lateral. Sorry, I didn't go to lateral. Yeah, lateral. Contrary to my expectation that right ventricle has accommodated this valve, I was thinking that it will be more restrained. Here it is looking restrained.
Yeah,
In
that's
the
right.
lateral it is restrained, but on a LAO it was flattened. Okay, ready for an angiogram?
Yeah, so I think the RPA looks all right, doesn't it?
Shiva.
Yep.
The proximal flare, somehow, I'm not sure whether all the hooks is coming out or not.
I saw it in a LAO. Show the LAO.
Okay. Thank you.
You see, okay, okay. Sorry, this RAO. You see, if Varakan, in this view, I saw both the little reduce the RAO.
Yeah, should be good.
Increase the cranial. It is
do an acquisition.
both looks. Okay, I'll do a cine. The one is immediately at the level of the hub, and the one is far more to the right side of the screen.
Yeah. Yep, excellent.
I will now try to reduce the it made a jerk there. Come to AP view, store this fluoro. I have a Cook long sheet, so I will come to the abdomen. Pramod, you can lock it and then advance. Yeah, keep going. That's the maximum. Fluorostore. Okay. Now show the top. Now, can you hold it? Keep seeing the valve. I'm just taking out. Unlike the Gore dry seal, which you can easily deflate, this is a rigid latex valve, and it doesn't go in. I want a pigtail here on this wire. Can we once again do one more angiogram in the RAO projection, Prabhu? Keep the dots horizontal, all the 3 dots. So go more cranial, more. Almost bring all the 3 dots to the. Yeah. Okay. Ready for one injection? Yeah. One lateral view.
Beautiful. And that shows the RPA. Distal flare and RPA relationship.
Yeah, but I think there is probably a shelf of the valve inside the ostia of the RPA, no, Shaq? In this view, a little bit of shelf on the under surface.
Yeah.
So, yeah, ready? Here, this shows the proximal flare quite dynamic. There is some PR, but I don't know whether I have a hole a little bit. I will just check the hemodynamics.
Yeah, you've got a wire and a pigtail.
Yeah, get me one pigtail. I will take a simultaneous PA-RV. We will also, after taking out this guide wire, I will show an intracardiac echo. Get the ice probe out.
Warren, how are we doing with time?
Actually, here in the CAT lab, Supra finished the case. So maybe we stick to Shiva until the end, which is almost there, and then swap to Supra's. Is that okay? Then, how many lectures that do we have now?
We just go by 2 lectures, so we have another 4 lectures.
And the webinar gonna finish when? Sorry.
As
5.
first, we try to finish in 5 o'clock.
Okay, so half an hour from now, right? About.
Yes.
Okay.
Go inside.
So let's do this very quickly.
Shiva, I missed your very first place. So this is 34 or 32 millimeter valve, sorry?
34, 34, 30, 30, yep.
Okay, right, thank you.
The measurements were between 30 to 31. Understand that show the pressures on a lower scale. I want at 20, 25 scales.
Siva, I just want to ask why you choose the Cook long sheet? Is it easily available there in India? Or do you want, is there any difference between a long sheet, core, dry seal sheet, long sheet? And my experience with Malaysia is I use a Medtronic Centron sheet. But there's some difficulty in pushing through the
Change
valve,
the color
so I
to
need
yellow.
Upsize,
Okay.
to French upsize a little bit more.
We don't have Gore dry seal registered in India. So I cannot.
Any experience with Medtronic Centron sheet?
Medtronic Centron does not come to, in India, it is in the 24 is available only up to 30 centimeters. We don't have the 65 centimeter Centron in India.
Okay.
Okay, tell us the pressures, Shiva.
The pressures
them.
bigger, the pressures are something like around 25. I'll show you large screen.
Yeah.
There is a diastolic gradient, Shaq. There is a diastolic separation.
Yeah.
And there is a gradient maybe of around 5 millimeters.
Yeah, no, that looks excellent result though.
Yeah.
Yeah.
So Siva, I must say that you excellent demonstration of your case, and I must say that you have the courage to do a live case with just a single valve and a single delivery sheet. That is something that is no one can do that.
And single plane.
Yeah.
Yes.
Yeah. And I must say that any valve can go for you because you're with a skill and high tolerance and a lot of flexibility, but maybe not for us.
Actually, Shaq trained all the Indian centers so thoroughly that maybe, what do you say, Shaq?
Yes. Yes. Sometimes having limited choice makes decision making easier.
Oh yeah, Shiva. If you can stay with us, maybe
I'm
Supra's
just
case.
I will get the ice probe facing the pulmonary valve, and you can see Supa's case and then come back.
Yeah. Okay. So if you can stay with us, because here is quite a roller coaster, I would say.
Yeah.
All right. Let's go to.
Thank you.
Warren.
Thank you, Shiva.
Yep. Shaq, can you
we
hear
see
me?
That. Yes. Yeah, we can hear you and see the echo.
Yeah. Srija is doing the imaging. Srija, you can describe.
Yeah, so this is an ice image. Hello.
Is Srija audible for you?
Yes, loud and clear.
Yeah, thank you. So this is
and better than Shiva.
Thank you. So this is the ice image which shows the deployed pulmonary valve. It shows the leaflets well and the stent frame of the valve. And this is the color image across, which is showing no regurgitation and good flows. And the gradient is, there's no gradient, this is around 8 millimeter mercury, the flow related gradient. There is no regurgitation at all. And the aortic valve, this is the aortic valve which shows some mild aortic regurgitation, probably the aortopathy of tetralogy. We can see the cross section of the stented valve. We can see the leaflets which are coapting well, or 3 leaflets. And that's it, yeah, I think.
Okay, brilliant.
Yeah. Thank you.
Superb pictures, Sridhar.
Thank you.
So now we
Even
are
better than Shiva's single plane, single valve, single everything.
yeah, thanks, Shak. Now we are closing the atrial septal defect. See the
Shiva, congratulations to you and your team too. A big round of applause for all of you.
Big hand,
it's
yes.
It's not yet over. We are closing the ASD. See
yes. Okay.
Yeah.
See the
so
problem.
is this single plane, Shiva? Because it looks like the ASD is across the venous valve at the moment.
See the problem, Shak. I have a long cook sheath, which is not allowing my delivery system to cross through. So actually, I had to push the entire cook sheath across the atrial septum. The problem is now the Amplatzer device is forming a cobra.
A cobra, yes.
Okay. Now, can you go on to thoracic? I will now. Thoracic. Actually, the cook sheath will not permit 2 ice catheter and delivery system together. So I took out the ice. I might bleed a lot if I have both. So now Srija is showing, and I am without fluoro. I am going to come back and approximate the atrial septum. Yeah. Now hands out. So now I'm. Now Srija again thoracic echo. The LV is looking dysfunctional.
There was a mild LV dysfunction.
Mild LV dysfunction, and there was some aortic regurgitation as well.
Yeah.
The patient is on carvedilol plus ramipril for a medical modification of this LV dysfunction. Maybe there is a little more AR, right?
AR, yeah.
Show the aortic pulse pressure.
Looks fine.
Yep. Okay. No, I'm not fluorine. I'm just connecting the. So Shak, the ASD device looks okay.
Yeah. I'm just trying to work out whether it's, in view of the LV dysfunction, whether it's worth closing the ASD just yet.
Okay. So I will do one thing. I will get in a pigtail catheter into the left ventricle to see what is the left ventricular end diastolic pressure. Yeah, there could be some degree of diastolic, elevation of the end diastolic pressure. It's possible. But Shak, when we know that there is an LV dysfunction, the shunt is going to go progressively high, and hence it's going to create more and more RV dilatation, right?
Yeah, but whether you stabilize things and then optimize the medical treatment and then close it or not.
He was already receiving carvedilol and one AC inhibitor for the last 2.5 years.
Okay.
We have been managing him. There was a MRI predicted LV ejection fraction of somewhere around 40, 45, I think. 45, yeah. It's a little dilated aortic root with, okay. Record left ventricular end diastolic pressure and aortic systolic pressure simultaneous. Yep. The end diastolic pressure, okay, that's fine. Aortic pressure. Show the LVEDP.
We can't see it.
No, we'll show that. Put it on yellow color and make the hemodynamics larger. Make the hemodynamics fill the whole screen. Take them. Okay. Show the. Okay. Now get it flushed. This is flushed. Backflow will not come. We have 5 and 5, no? Okay. The end diastolic pressure is touching 20 stack. We will give some furosemide. We will give some furosemide, and we'll be able to control it.
Yeah. So I think all it means is if you go ahead and close the defect, the patient will need sort of very careful management afterwards over the next 24 hours, doesn't it?
Yeah. So the patient is right now intubated. So we will, as we are extubating, we will give some more diuresis. It's somewhere around 20 shack, 21, 22.
Yeah.
Already we saw the pulmonary artery pressures were normal. So the device, I will release it now. Shall come to fluoro again. Fluoro big. So this is a Trevisio cable. So it's.
What was the size of the device?
The size of the device on balloon stretch was around 16, and we used 18 or 20? Huh? 20 millimeter device.
Oh, you had a choice.
Yeah.
Yes, you have a choice.
Varakan, I wanted to know about what is your method of groin closure. Is it ProGlide or is it figure of 8?
Yeah, ProGlide for super.
Okay.
How about yours?
No, figure of 8.
Okay.
So Varakan?
Yep.
I think Shiva's done a brilliant job as well,
Yes.
the whole team.
Yes.
So we should give them a big hand.
Yeah,
That was an excellent case.
I would like to thank Supa, Varakan and Shaq for giving us this opportunity, and I convey my sincere thanks to the entire team, Venus MedTech from including Joyce, who were instrumental in arranging this transmission across the Southeast Asian countries. Thank you very much.
Thank you, Shiva. Thank you.
Thank you, Shiva.
Thank you very much.
Thank you, Shiva. Well done.